All right, good morning, and thank you very much for this opportunity to present a project entitled Improving Rates of Preventive Health Screening in Individuals with Obesity, a Possible Role for a Specialty Surgery Clinic. First, I'd like to acknowledge the Department of Surgery Research Seed Fund Program, which made this pilot project possible, and the research team, specifically Kara Liebert, Daniel Stoltz, Aida Brun, as well as Carolyn Seid and Jamie Pratt, and from Espire, Kate Arno and Nick Barretto. In order to put this pilot study in context, I'm going to spend some time on background. Specifically, I'll talk about preventive health screening in the population with obesity. Then I'll talk about the VA Palo Alto model for a bariatric surgery clinic. I'll then briefly describe the study design. I'll discuss the results, and then we'll discuss some possible next steps and future directions for the study. Our general hypothesis is that a specialty surgery clinic within an integrated healthcare system can improve rates of preventive health screening. So let's talk a little bit about preventive health screening. Now, we all have an intuitive idea of what that means, but the WHO describes the rationale as to identify people in an apparently healthy population who are at higher risk of a health problem or a condition so that an early treatment or intervention can be offered and thereby reduce the incidence and or mortality problem. So strategies for screening are actually designed to target the healthy population. And you can see in the diagram, the healthy population is the one that undergoes health screening with the idea of identifying the few who may be at risk of a disease or care. And there are several screening strategies that are put forth by different entities, advocacy groups, professional organizations, and government agencies. Veterans Health Administration uses the National Center for Health Promotion and Disease Prevention for guidelines. National Center for Health Promotion and Disease Prevention, or is a national program of the VHA office, which is meant to provide VA clinicians with evidence-based health promotion and disease prevention. The NCP produces grids that look like this, in which the y-axis shows us the disease entities and the x-axis is, and the health recommendations form the grid, where red boxes are in which screening is not recommended. Green boxes, screening is recommended. And the yellow boxes is where the individual patient-provider decision needs to be made. But we know that there are populations at risk for low rate. Here's an example of a study from the Mayo Clinic Health System, which is an integrated health delivery system in Minnesota, Iowa, and Wisconsin. The electronic health records to look at cancer screening rates. Based on US Census data. And their objective was to examine the association between ADI, rurality, and cancer screening. Is that better? Okay. All right, so let's start over. No, I'm kidding. So the objective of this study was to assess the association between ADI, rurality, and cancer screening. And they looked at factors associated with cancer screening completion, in this example, colorectal cancer, and they identified social determinants for cancer screening. And they saw that increasing of the ADI, or increasing of the index, was associated with a decreased odds ratio of completing colon cancer screening. They also found a similar pattern for the other cancers. Importantly to note here, they didn't specifically look at obesity or BMI. But we know that individuals with obesity are a population at risk. Here's an example for colon cancer screening. The odds ratio of completing colon cancer screening decreases at higher classes of obesity. Similarly, for cervical cancer, increasing BMI is odds ratio of cervical cancer decreases with increasing BMI. Also for screening mammography, see a similar pattern, odds ratio decrease with increasing class of obesity. And we know that cancers are associated with overweight and obesity. Individuals with obesity are at increased risk of multiple cancers, as seen here in this diagram from the National Cancer Institute. And just another final example, relative risk of postmenopausal breast cancer increases linearly with increasing in weight gain. But to shift gears a little bit, I want to talk about our specialty surgery clinic at the VA Palo Alto. The Metabolic and Bariatric Surgery Weight Management Center at the VA Palo Alto provides services to a geographically dispersed patient population. We treat patients from different areas of California, as well as Washington, Oregon, Montana, Idaho, Nevada, Arizona. So a way to deal with this challenge, we've developed a fully integrated interdisciplinary clinic, which is modeled on the hub and spoke model of care, in which the Palo Alto Clinic forms the hub and all the referring facilities are the spokes. So let's take a little closer look on the function of the clinic, and I'll put our study in a bit of perspective. So the provider in the home or spoke facility initially consults the VA Palo Alto for assessment for bariatric surgery. The patient undergoes assessment and evaluation by a bariatrician, a dietitian, psychologist, and physical therapist who discuss and come up with management plans in real time. In addition, there's real-time communication with the provider in the home facility. This iterative process continues until the patient is presented to the surgeon for evaluation and finally undergoes bariatric surgery. Which brings me to our hypothesis. First, that health screening in veterans seeking bariatric surgery, in effect those with a BMI greater than 35, is incomplete. And two, that rates of screening increases after participation in a multidisciplinary bariatric surgery clinic within the VA's integrated healthcare system. Now, this is a question of some interest in the US Department of Health and Human Services. On their website, you can see how to increase preventive screening rates in practice, a toolbox and guide. And they come up with these 5 ideas. 1, don't forget to recommend screening to your patients. 2, develop a screening policy. 3, have reminders. Measure progress. And finally, communicate. So essentially what we're hypothesizing is that there will be a difference between the health screening completion rates at the initial consultation to our clinic compared to the time in which they go to surgery after they've gone through the entire assessment and evaluation and management strategy by the interdisciplinary clinic. So it's a pretty straightforward design. It's a retrospective cohort study, consecutive patients undergoing bariatric surgery at the VA Palo Alto. We looked at patients from January 2010 to October 2021. We excluded those that had incomplete records and those with revisional bariatric surgery. We looked at the age and sex-appropriate health screening guidelines based on the NCP, including cancer screening rates for breast, cervical, colon, and lung cancer, as well as AAA, HIV, and osteoporosis. And this is what we found. First, at the initial consultation, patients that just were consulted to the clinic, there were 381 patients that met the inclusion criteria. The mean age was over 50. The vast majority were male with a BMI over 40. Many of our patients were smokers, had osteoarthritis, diabetes, hypertension, sleep apnea, hyperlipidemia, and mental health disease. So this is what the typical VA bariatric patient looks like. Older and male, which is very different from the bariatric patient in the general population, which tends to be younger and female. To emphasize the point, this is the global registry of bariatric surgery patients and their comorbidities. You can see here dyslipidemia, obstructive sleep apnea, hypertension, and type 2 diabetes. And you can see in the bariatric surgical patients in Asia, Middle East, Europe, Latin America, and North America. It's a pretty heavy comorbidity burden. This is the VA population. Again, to emphasize the point that it's a different population than what is typically seen in the bariatric surgical population. We found that at the initial consultation, only 39.1% of our patients had all their screening tests complete and up to date with guidelines. What surprised us a bit was you can see here that cervical cancer rates, breast cancer screening rates, and colorectal cancer screening rates were all quite high at initial consultation to our clinic. We looked at the factors that were associated with being non-concordant with the guidelines at the initial consultation. And we saw that older age, higher BMI, lower median income, and presence of comorbidities such as osteoarthritis, diabetes, hypertension, and PTSD were all associated with being non-concordant at the initial presentation. We were surprised that minority status was significantly associated with being concordant with all screening guidelines, and that distance to the nearest VA medical center did not seem to be a significant factor. So what was the impact of the bariatric clinic? So again, at initial referral, 39.1% had all the screening tests complete. This increased significantly to 63.8% after going through the clinic and at the time of surgery. So we looked at the factors that were associated with non-concordance at the time of surgery. And again, we saw older age, male sex, lower median income, again, former smokers, and comorbidities such as diabetes, hypertension, and PTSD. Now you'll see here that looking at each individual test, at the initial referral, by the time patients came to surgery, each of the tests improved screening rates. Even those with cervical cancer, breast cancer, and colorectal cancer who were high still increased at the time of surgery. But significance was found for HIV, cervical cancer, and colorectal cancer. What was interesting and to highlight here, for colorectal cancer screening rates, it was 92% at the time of initial referral, increased to nearly 100% significantly at the time of surgery. So we looked at the factors that showed what was the patient factors that were non-concordant at initial presentation and failed to progress to concordance despite going through the clinic. We found increased distance to the VA at this time did make a difference, and a history of smoking. But we were surprised that the number of indicated screening tests was not significantly associated, and number of medical comorbidities was not a significant factor in preventing patients from becoming concordant. Finally, we want to look at our clinic performance over time, and we see that in the beginning, in 2010, to the end of the study in 2021, the clinic's ability to convert patients from non-concordant to concordant improved. The multiple limitations to this study, this is a pilot study, it's small sample size, any small number of patients overall for all the tests, but also there are specific screening tests with very few patients, such as lung cancer screening. This is a male predominant population. We did not rigorously evaluate social determinants, and we did not evaluate the generalizability of our results. This is an entirely veteran population, and it is a single site within the Veterans Health Administration. Nonetheless, we think that this is an opportunity to impact overdue health screening. There is a minority of patients with BMI greater than 35 referred to bariatric surgery clinic, completed all recommended health screening. Older age, higher BMI, lower median income were associated with missing screening tests. Screening rates for breast, cervical, colorectal cancer are high, and screening rates for lung cancer and HIV are low. But a dedicated multidisciplinary specialty bariatric clinic that interfaces with the primary providers can improve screening rates. Significant gaps remain. In our future study, we'll use national VA data to assess screening rates of veterans with obesity versus those without obesity, to determine the interaction between social determinants and obesity status, assess the impact of referral to bariatric surgery on screening rates. Keep in mind that there is no national standard for bariatric surgery clinic protocols. And we'd like to assess the facility level screening performance, whether the presence of a bariatric surgery program correlates with improved screening rates, identify barriers and facilitators to reduce rates of overdue screening, and thus define the role of a specialty bariatric clinic within VHA. Thank you very much.